Hi, everyone, and welcome to our webinar on MIPS Audit Binder Essentials, what you need versus what you don't. My name is Chelsea Grover, and I'm the Marketing Manager for DAS Health. Before we get started on today's webinar, I want to take a moment to explain the process for the presentation. First, I'd like to mention this webinar will be recorded, and that we'll send out a copy of the slides along with the recording within the next week. Next, I see a number of new folks have joined with us today, so this seems like a great time to do a quick reminder of who DAS Health is. DAS Health is a leading provider of health IT and management solutions and a trusted consultant to many physicians groups, hospitals, and healthcare systems across North America. We offer a full range of business and technology solutions to help you in your practice, including consulting services, RCM, remote patient monitoring, MSP managed IT services, hosting, security, and compliance, just to name a few. If you'd like more detailed info on any of that, just drop us a note in the questions area and we'd be happy to fill you in. Next, I want to mention that we have a bunch of great webinars coming up soon. Next week, we'll be presenting Cybersecurity webinar on the human factor, the weakest link in data security. Cyber criminals are sending social engineering and phishing attempts to trick your users into giving them access to your data. Join us for a webinar to discuss how humans play a significant role in cybersecurity, threats to look out for, and strategies you can implement to address your weakest link. Then in early December, we'll be doing another regulatory webinar on making sense of your regulatory landscape for ambulatory practices in 2023 and beyond. And then at the beginning of the new year, join us for Stop the Manual Madness, Maximizing a Prima for MIPS. So make sure to keep your eyes out for those exciting webinar invitations in your inbox. And of course, follow us on LinkedIn and social media to stay up to date on tech tips and webinar announcements. Okay, so back to today's webinar on MIPS Audit Binder Essentials. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Bridget Pearson, Lindsay Lanning, and Kimmy Watson are all joining us from the DAS Health's Government Incentives Department, and we are truly compassionate fanatics and looking forward to discussing audits with you today. I was going to call them nerds, but I thought that might be a little insensitive, although I truly do think that they embrace that term. So without further ado, Lindsay, I'll go ahead and hand it off to you.
Perfect. Thank you, Chelsea. Yeah, we'll wear that title with pride over here. We are compliance and overall MIPS nerds. We love it. So thank you again, and thank you everyone for joining us on this Tuesday afternoon, maybe even morning, depending on where you are. We are here today to look at your MIPS audit binder, what you need versus what you don't. I actually have to make a confession. This is a trick title. There really isn't anything you don't need, to be fair. The more documentation, the better, in my opinion. What I do want to use our time today is to go over, what you absolutely need in your audit binder. We want to make sure you leave here today feeling confident that you can be prepared for an audit and will know how to navigate one when you're selected. And yes, I say when, not if, because that is the reality we're dealing with right now. So I feel obliged to do the responsible thing here and warn you that this presentation may contain overwhelming and somewhat frightening material regarding MIPS audits. This may lead to increased stress levels. Please view at your own risk. Now, I'm not seeing our numbers, dropping drastically over there, Chelsea. So I think we're okay. I think most of you knew what you're getting into today. I will admit, we did this as a kind of a sort of a whimsical way to introduce this topic, but it is true. I'll be honest. Audit isn't a very pleasant word for most people to hear. The fear of being caught for some little mistake or missing a checkbox here and there can really strike fear into even the bravest of documentation experts. For our providers, submitting under MIPS, there are thousands of dollars on the line, and that can be overwhelming and definitely somewhat frightening. But that's why we're here today. We're going to share with you exactly what to save in order to avoid failing an audit. Because I'll be honest, failing an audit, whether it be an old meaningful use one, Medicare or Medicaid, a HIPAA one, or even a MIPS one, it's much more common than you would think. But before we get started on how to prepare, I want to ask all of you a few questions to evaluate how ready you are right now for a MIPS audit. So number one, did you submit data under the MIPS program anytime from 2017 to 2021? Yes, every year. Yes, at least one of those years. Nope, we did not. We didn't participate in MIPS. Maybe you've never heard of it. Maybe you're just getting on today to see what all the fuss is about. As we're seeing the responses coming here, we'll give you, you know, one minute or so, maybe 30
Give
seconds.
everybody a few more seconds to finish up here. It looks like we've got about 68% in, so we're almost closing in there. And these are some pretty interesting numbers, so I'm excited to share these.
Yeah, definitely. Oh, okay, I see. So sorry, everyone. We can see the background over here, and then we get to share with you. We've got the insider information over here.
Okay, so let's close this in 5, 4, 3, 2, 1. Okay, should I show them, Lindsay?
Yes, please.
Okay. Here
Perfect.
We go. You can see where you stack up.
So we're seeing, you know, the majority here, which to be fair, I did expect a yes every year. You know, once you're eligible under the MIPS program, typically it happens every year. So I'm not surprised to see that be the highest. We do have a decent amount more than I would have thought for at least one of those years. So maybe the eligibility status changed. Maybe, you know, you participated under at least one of those, and then, you know, we had COVID-19 hit, and we had some hardships applied, et cetera. It looks like we did have a few no responses as well. So I will be here to say welcome to you today. And, you know, this will just be good information for 2022 forward. So basically what I'm getting is about 97% of you on this call today reported under the program. So for those who said yes, we can launch the next one, Chelsea. For those years you participated or you reported, do you have a complete binder or folder of attestation data for each of those years? And have you already started one for this year? So again, if you did submit under, you know, either one or all of those years, trying to figure out where we're currently at or what our current status is. So yes, of course, with an exclamation point, you know, absolutely, you're a MIPS vet over here.
You didn't really give anybody a half attempt here to answer, did you, Lindsay?
No,
they were all in or nothing.
No. I think the middle one is I think I saved some stuff somewhere. You know,
is that the same place that my missing socks go when I do the laundry?
Exactly. So, you know, if you think you gathered, maybe you remember saving down your certified EHR technology ID. Maybe you remember exporting some reports here and there and you saved them down, but, you know, I don't remember if I printed them or if I saved them in a folder or where that folder is. Maybe that second option is best for you. And then, of course, our third option, in a kind of, again, a whimsical way here, but what's an audit binder? So that really being the option of, no, I don't think we have anything saved, either because we didn't participate or, again, because, you know, we didn't know what we needed to save or that we needed to save things for a certain amount of time.
Okay, so it looks like we still have a few more people waiting to answer here, so we'll give everybody another, I'll call it 10 seconds. So we'll close this in 5, 4, 3. Ooh, we got a few more in. 2, 1. Okay, let's go ahead and close. Let me share these. Here you go, Lindsay.
Perfect. So you can see, again, the majority here, kind of a similar breakout, but a little bit less. So we are at about 60% for yes, of course. That's awesome. I love to hear that. I still think in our webinar today, if we ask those same questions at the end, which, you know, could have been a little bit of a fun exercise here, but I don't want to do that. You know, would that same confidence be there with everything that we're about to go over today? I think this will be a good reminder of, you know, maybe some items that you didn't have in there that maybe need to be tucked in there. We have about 30%, as I think I saved some stuff somewhere. I can relate. I completely understand, you know, if you've had a lot of transition in your office happening, you know, if you've had a lot of turnover, sometimes that can cause some issues with finding that data and where to save it. And then that 10%, what is an audit binder? Buckle your seatbelts, folks, because you're about to get a ton of information, kind of drinking from a fire hose today. So we've got the information you need. And then last but not least, kind of our last question here today, and we'll really jump into the material, would be if you received an audit letter or an email today, could you have all the information CMS would request from you within 45 days? So our first option, again, is going to be, yes, I'm ready. Our second option is going to be, I'm pretty sure I could figure it out, but I'm not going to say I'm confident. And then 11, or right around, you know, our last option here would be right at no way. Sorry, but I don't think I'd have that. You know, I don't think 45 days would give me enough time, or I don't think
owning up to that right now and knowing that that's where you're at, that's okay. Like, you're here. That's why Lindsay is going to be helping you through this right now. There's still hope.
Yeah, so I was going to say, I would like to reiterate, this is a safe place. I swear I'm not an undercover MIPS auditor. Be kind of cool. Just kidding. I do love my job. I love my team. And honestly, I'd probably pass everyone because believe me, I know how hard it is to get this information together. So I love that transparency here. So if you are at that no way stage, no problem. Today is going to be super beneficial for you. I think, Chelsea, we can give it a little bit and we'll share.
Sure. Yep, so we'll go ahead and give this one another 5, 4, 3, 2, and 1. So let's share these. Ooh, somebody just snuck in under the wire. Okay, here you go.
Perfect. So what happened to all my confident, first answers? I feel like a lot of you, shifted to that middle option, that I can probably figure it out, but I'm not, 100% confident, which I understand. Again, I mentioned these audits can be intimidating. So I did kind of expect our majority to be here, which is a good thing. Like I said, if you're in that second bucket that I can probably figure it out or the no way, I think this will be extremely beneficial. And if you're, like I said, in that yes, I am ready, I think this will be a really good review because there were some changes for, especially the 2022 program year that would actually adjust your audit binder. So if you've been kind of following that same cadence year to year, there are actually some changes this year to make note of for your 2022 audit binder.
Okay, well,
So
with
thank
that,
you,
Lindsay,
Chelsea.
we'll go ahead and let you, I'll hide this and I'll let you get on with your teaching.
Perfect. Thank you. So again, these questions weren't meant to send anyone into panic mode. It was really to bring to attention the fact that a lot goes into preparing for an audit, and it can be intimidating, but it is possible if you understand the process, if you anticipate what will likely be expected of you, and the key to it all, staying organized. I like to think of it as preparing and protecting your practice through documentation, action, and knowledge. So now that I completely overwhelmed you, apologies again, anyone who got maybe an Apple Watch notification for an elevated heart rate. You'll be okay if you can believe it. I get one of those literally every webinar, and I'm just fine. I'm over here talking with my hands and doing all the motions, but you'll be a-okay. But to make this more manageable, we're going to break this down, starting with the process and ending with what's needed. So let's quite literally start with the basics. What is an audit? Now, according to Webster, it's going to be an official inspection. However, CMS likes to refer to their audits as a data validation process. CMS is very fancy like that. So CMS MIPS audits can actually be done randomly, or they can be done part of an investigation. And they really are trying to review all the information submitted during your attestation for MIPS. Again, I want to kind of lay on the ground like a toddler in a grocery store who didn't get their double stuffed Oreos when it comes to audits, but they are required. They are by law necessary to ensure the integrity of the program. Have you ever heard the phrase trust but verify? Well, this is that. CMS really has to prove the program is operating with accurate data in order to be successful and to continue on. So who is eligible for an audit? And sadly, it's any clinician who has participated in the MIPS program may be selected for an audit. If selected, you must comply with all data sharing requests. So that means even if you weren't eligible for that year, but your practice submitted data at the group level and it included your NPI, it would apply to you. Any form of participation in MIPS will make you eligible for an audit. Now, with little surprise, after MIPS audits were actually announced, COVID hit. And on March 30th, 2019, CMS actually suspended all Medicare physician fee schedule reviews, which actually included the MIPS data validation audits. After about a year and a half, in July of 2020, you can see the FAQ on the screen. CMS came back and said it would resume these audits as of August 3rd, 2020. And it would continue with new audits regardless of the current public health emergency. Well, they must have resumed them and really not liked what they saw or found, because 2 months later, CMS actually came out with the announcement on the right, basically stating if you were selected for a MIPS audit, or what they're calling, that DBA process for years 2017 or 2018. It was purely educational. No actions are going to be taken. You can still get your feedback, but essentially no money is going to be recouped from you. Now, this does not mean audits are over. They are currently happening for years 2019 and beyond, and CMS says it will conduct the data validation audit process annually. There's a lot of money on the line, being distributed to providers with this program, which is why the audit process is in place, and they can take that money back if you can't pass an audit. So we know why they're doing it, right? But how do they go about choosing who will be subject to an audit? What specifically causes a MIPS audit? Well, these DVAs can be random, so you can be selected out of a random pool of providers for an audit. CMS did actually state there is some rhyme or reason to even their random audits because they want to make sure they include a good sample selection for a variety of clinician types. You know, think urban, think rural, think large or small practices, as well as a good mix of submission methods. So, you know, we can submit through your EHR or a registry, even claims-based reporting or a QCDR. So they want to include a good mix or variety of all of those options here, even in the random audits. They're targeted. So there are numerous reasons on how this could be a targeted one, including a failure of a previous audit, whether it be an old meaningful use audit, maybe you failed a HIPAA audit, or maybe even those 2017, 2018 DVAs that they did, you know, educational only, that they didn't take action on. If you failed one of those, you know, you might kind of be put in line for a future year for an audit. Now, the failure of a HIPAA audit may surprise many of you since HIPAA audits and MIPS audits are supposed to be completely separate, right? They're independent of each other. Well, wrong. We've learned that even though the OCR, the Office for Civil Rights, is the enforcing arm of HIPAA, and CMS, or they contract with Guidehouse, is kind of the enforcing arm of MIPS, they can report failed audits to each other. It's up to their discretion. So one very key element that overlaps in both MIPS and HIPAA is the security risk analysis. So if you fail a HIPAA audit, there's a good chance OCR could reach out to CMS and say, hey, X number of providers failed a HIPAA audit. Pretty good indicator that they might not be MIPS compliant either. Along the same lines, you know, a previous meaningful use audit or even those, you know, 2017, 28 MIPS audits, some people believe that once you fail a meaningful use audit a few years ago, you're basically automatically scheduled for an audit for a different payment year. Now, we can't prove this, again, and CMS has not specifically said anything about this, but it does make sense. You know, these audits are in place to ensure incentive money is going to individuals who are actually meeting the program. So if you attested you were and then failed to prove this in an audit, why wouldn't CMS flag your name and come back and check up on you? And then finally, one that's probably the most surprising and kind of unnerving here is the failure of an audit by colleagues. More and more, we're seeing that one provider or practice is being audited who fails, and it just happens that in the next few years, colleagues in the same practice are also being audited. You know, in CMS's eyes, this makes sense. If all the providers in one practice have similar workflows, similar, you know, care methods, policies, and procedures, it could be a good indicator that more than one provider may not be in compliance. So we know MIPS data validation audits, you know, were conducted on a select number of clinicians in 2019 for 2017 and 2018 performance years. According to CMS, Guidehouse is the contractor who's been tasked with conducting these data validation audits, which are said to be processes that will help ensure MIPS is operating again with that accurate and useful data, and just make sure that everyone is required to comply with those data sharing requests. So that is their official announcement that you're seeing on your screen here. So let's break this down. How do you know if you were selected for a DVA back in 2019? Well, I really hope it hasn't taken you 3 years to figure this out. But also for those of you who could be selected in the future, this same process, as far as we know, will still apply. So CMS said if you were selected for an audit, you would receive a request for information from Guidehouse, and it would be sent either via email or certified mail. Those initial requests for information are sent out in June or July each year. So we are kind of past this point now, but a good reminder for in the summer to keep an eye out. If it was sent by email, it would have the subject line notification of data validation, performance year, and insert that year. You would then have 45 calendar days from the date of that notice to provide the requested information. And per CMS, if you don't provide the requested information, they can take further action, including that you'd be selected for future audits. Now, something to note that's different from previous meaningful use audits is that these DVAs are actually done by category. So MIPS has 4 categories, right? Quality, promoting interoperability, cost, and improvement activities. Well, the number of measures or activities selected for these audits from each MIPS category will actually mirror the weighting for scoring for that year. So what this means, in 2018, right, the quality category is weighted at 50%, improvement activities at 15%, and PI at 25%. that means that 50% of the total audits conducted will be for quality measures and only 15% for improvement activities. Same thing, in 2021, those weights changed or fluctuated a little bit. Only 45% of the total audits will actually be for quality measures. And again, what you'll notice is that CMS is not going to conduct any audits on the cost category. There's no need to audit the cost category because we don't submit any information. It all comes from claims data that they're gathering themselves. So you can see, again, improvement activities really have the lowest chance for an audit, then promoting interoperability, and then quality. Now, this has changed, as quality has become lower in weight over time. Really, we're at the point now where it's really evened out to almost every category is almost equal for chances of an audit. But again, pay attention which category you're selected for. You could be selected for a quality audit in 2017 and then an improvement activity audit in 2018. There are no rules against this. But again, I think it goes without saying, with all the hardships that we've had over the past few years, you're only ever going to get audited for the data you actually submitted. So if you took a hardship for COVID-19 and you didn't submit anything, there is no chance you would have a data validation audit for that year. We still don't know if CMS plans to audit for the hardships or not. We always err on the side of caution, and we want documentation to support those as well. So let's look at a MIPS audit by the numbers. You have 14 days to acknowledge. So that means acknowledging the audit by responding to confirm, yep, I received this email or I received this piece of mail, I'm aware. You have 45 days to actually submit your supporting documentation, which is not a lot of time unless you have everything saved and labeled and ready to go. And you have 6 years that you're required to retain your documentation in case of an audit. So MIPS started, back in 2015, let's say. That means you're safe from the first year at this point, but every year after, could still be fair game. Now, to make life easier, CMS did come out with a MIPS data validation zip file, and it's made available every year. So the audit requirements are maintained in these files for each performance category and are going to provide you more guidance. They also, provide these to the auditors as well. So to access them, you would just follow the steps on the slide. You would be going to that QPP website through the resource library. So it can be helpful to review these requirements as you build your binder so you know exactly what an auditor is going to expect of you. I find the improvement activity one to be most helpful, as most of those activities are left pretty broad, and the validation documentation section will actually give you ideas or examples of exactly what they would want to see during an audit. So you can see on the screen the PI file and the improvement activity examples. Here, the activity that we have is 24/7 access. And you can see that specifically the auditor would actually want to see a patient record from the EHR with a certain timestamp, maybe an encounter or a claim, again, showing care outside of the practice's normal business hours, or even that same or next day patient encounter, medical record or claim, that same day or next day documentation. So as you can see, that same day or next day appointment, that wouldn't be something I would have immediately thought of for proof of this. So I highly recommend reviewing this document for whatever activity you choose. And again, for PI as well, to give you some good ideas. So what if you are selected? Again, let me phrase that, since it really isn't a matter of if, but when you're selected. Now that you know what the process is going to look like, let's dive into how you can prepare starting today, this afternoon, if possible. So I recommend you start with specific MIPS category documentation. You should have it in your audit binder for each year, so we'll start there as well. First is actually going to be your eligible clinician information. So you need to know who is associated with your practice each year you report. For some, this is going to be super easy, particularly if you're a smaller practice with a low turnover. For larger, multi-specialty practices that have higher turnover, this could be a bit harder, but again, even more crucial. So we recommend exporting or creating a list of every NPI that practiced at your tax ID that year, whether they are still there or they left that year. Because remember, if you're reporting as a group and they billed out under your tax ID at all, let's say in 2022, you need to include them in your data. Then we recommend highlighting any eligible clinicians under MIPS, who are individually eligible, and putting an asterisk next to any that may be reported individually. You can then log into the QPP portal and review who CMS has actually identified as associated to your tax ID for that year. Again, we recommend doing this specifically after that last snapshot period in November, which is coming up here, to reconcile your current list versus what CMS has in mind of who's at your practice. When you are in the QPP portal, it's great because it'll actually show you the statuses of each one of your clinicians, which you can export and save. Otherwise, you can do this manually. Let's say you don't have the QPP login for your practice. You can technically look each NPI up manually on the QPP lookup tool without being signed in and see their status for that year and screenshot it and save it down. So if they're eligible or ineligible or if they have any special statuses. So either way, we encourage you to save these down. So if a provider, like I said, was eligible or not, maybe they were part of an APM and that's why you didn't report, or maybe they had a special status designation like a small practice or non-patient facing, because that impacted how you reported. Now, don't panic if you haven't been doing this for each year. You can always use the lookup tool by NPI to go all the way back multiple years. You can also see this information in your QPP portal as well. So there is a way to retrospectively go back and do that. And theoretically, you should always have access to this. But again, in case you ever got locked out, I think it's a crucial thing to have in the very beginning of your binder for each year. Okay, so let's get into each category's documentation, since we know audits are done by category versus the entire program. So let's start with promoting interoperability, or PI, because this category definitely has the most audit documentation associated with it. So to recap, under PI, you have measures that have data, think numerator and denominator, actual performance rates that you track, likely using your EHR or some sort of registry or dashboard. These are going to be e-prescribing, HIE send and receive, so sending and receiving referrals electronically, or CCDAs, and then that patient portal access. But you also have attestation measures under PI that you simply attest yes to, but then you have to have documentation to support them. So those are going to be things like your security risk analysis, prescription drug monitoring program, or the immunization electronic case reporting. There's also documentation to prove you were using 2015 certified EHR technology, as well as some other reports that support specific measures like e-prescribing, things like drug-to-drug checks or drug-to-allergy checks, and we'll go over all of this. So to start, the easiest are the measures with data. They're easy because you just need to export your certified report from your EHR or registry dashboard. Here are some things to keep in mind. You want to export the report when you submit, so your numbers match exactly with what you submitted. If you download them too early or too late, there may actually be very slight changes in percentage or data as maybe encounters or notes close and lock. Also, some of the PI measures have exclusions. For instance, if you prescribe less than 100 prescriptions within your PI reporting period, because again, it only has to be 90 days, then you don't have to report the e-prescribing measure. You can actually claim an exclusion. If you claim the exclusion, I would run your PI report showing the denominator is actually under 100 before you remove it from your configuration, so you have proof it was actually under 100. Same goes for the HIE send and receive measures. You want to have proof of those exclusions or why you were under that number. You also don't want to forget to run the detailed reports. So these are going to be the ones that show you the patient information behind those numbers on the report. You should have a way to view and download which patients, counted for you or against you for each measure. You want to save this because when you are audited, they want you to prove you did the required actions for those measures. So you're likely going to have to show them patient examples, which when you have these reports are going to make it really easy to go back and pull because again, we only have 45 days. We also recommend taking workflow screenshots or saving down workflow white papers or informational guides on them if you have them for that year. That way, again, if you leave and someone else is in charge of this process in a few years, or you change EHRs or upgraded, et cetera, it looks completely different. You can show them how it was done if they ask. Next, you actually want to download your, again, CERT, that Certified EHR Technology ID, which if you're submitting via certified registry, you actually have to input anyway in order to actually submit. But to get this, you would just need to go to the Chapel website, that chpl.healthit.gov link you're seeing on your screen, and search for your EHR vendor. It'll look like this. You would then find the version or versions you were on during your 90 days, likely only one, but if you did perform an upgrade mid-reporting period, you may have to select 2 of these. and you would hit that plus cert ID, that yellow icon, to essentially add it to your cart. We have some online shoppers here. You're familiar with this process. And then again, once you have all the versions or version added, you would go ahead and hit that Get 2015 EHR Certification ID. It'll give you this special ID and allow you to save it and export it as a PDF and add it to your audit binder. You do want to make sure when you look up your EHR and add it to your cart that 100% of that base criteria shows it's met. Otherwise, your EHR is not certified. Unless you use another software in conjunction, with your EHR to cover that unmet portion, that could be the case as well. Also note that the new cert version required for reporting in 2023 is popping up. That's what you see that 2015 CURE stands for on the left-hand side of your screen. So you can also start looking up your EHR now to determine if it's 2015 CURE certified and what version it is that you need to be on starting next year. For MIPS, you just need it no later than your PI reporting period. Again, 90 days. It could be as late as October. Obviously, we're encouraging everyone to get it as soon as you can, but keep an eye on that as well. Great segue for us into our next document that you should have, which is a report showing your system's upgrade history. I think you probably understand why you need this now based on the different EHR version requirements that have kind of changed over the years. We've seen a bunch of different ways to do this. Sometimes your EHR does this for you and will send you a letter. Sometimes you can run a crystal report or a SQL query in your system and give you that data yourself. Again, typically just depends on the system that we're working with. You'll also want to make a copy of your EHR license agreement or any invoices from your original purchase. If you have this in your binder from previous years, that could be one thing you could bring forward each year. Again, the more documentation proving when your EHR was installed and what versions you were on, including any sort of hot fix or latest patches you're on, the better. Think again, 6 years later, this could be completely unknown if we've had a lot of staff changes. Now, the next report we may want, it might seem a bit odd, and again, I'm not actually positive this will carry into MIPS audits. We saw this a lot, and even this year have seen this a lot for old meaningful use audits, and that's the patient seen using the EHR report. We would help clients meet this by running an appointment log report to show the appointments that took place, and compare it to maybe like an encounter list for that whole year. We've also run it in some client system by using for different procedure codes that are used or typically billed for as well. It just depends on your system and how data is stored. We've also seen EHRs who already have this as a saved or memorized reports because it was needed for audits so often. But it's just a good one to have for which patients you saw using the EHR during that time frame. Now onto the documentation needed to support some of those PI measures, on that certified report. The first is going to be e-prescribing. So the e-prescribing measure itself also includes an optional bonus measure. It's called the Prescription Drug Monitoring Program, or PDMP or PMP. It's usually state specific, and it's when your providers prescribe a controlled substance, if they look the patient up prior to doing so to make sure they don't display any of those drug-seeking behaviors or they aren't already on something. This is optional. It's actually for bonus points. For previous years and for this year, it has been proposed to be mandatory for everyone for next year. And I say proposed because we haven't had the final rule out. It should come out, in a few weeks in November, but kind of keep that in the back of your mind as well. But if you did attest yes to this measure for bonus points last year or you're trying to this year, you want to have proof of this on file. This can either be through your EHR or manually outside of your EHR through like a website portal for your state PDMP. Most clients we work with can log into a portal and actually export a report for the whole year, showing when each provider looked up a patient. Super easy. Or if it is through your EHR, it's likely included on your certified report, or they can give you a report. You just want to make sure you have at least one example during your designated PI reporting period. You can see actually on the screen the CMS case I included. They confirmed one provider one time during the reporting period will get you credit for this if you're doing group reporting. I am going to throw this out here. This is different than getting credit for this for the improvement activity category. A lot of our clients who claim this for PDMP bonus in the PI category also use this for credit in the improvement activities. Two birds, one stone. It's great. I support it. Just beware for the improvement activity requirements. They're more stringent. So you have to have 50% of your providers in the practice doing this for over 75% of the instances that it's required. So, again, PI is a little bit easier to meet. IA is a little bit more difficult. So if you are trying to do that, you can't use these same requirements. That was a bit of a tangent. Sorry, I just can't help myself sometimes. So back to the measure-specific documentation. For our next measure, or measures really, the HIE send and receive. This is that sending and receiving of referrals and CCDAs electronically within your EHR. You should have numerator denominator data on your report to either report or exclude from these measures. But as of last year, CMS actually introduced a third option, which is the bidirectional exchange attestation. So if you participate in a health information exchange or an HIE, and it actually automatically queries or sends or shares patient data, you could get full credit for both of these measures and it just attests yes. You do need to be able to prove it in an audit. So CMS specifically recommends having a letter, an email, or some sort of documentation on file, either from the entity that you're contracted with. So a good example of this that a lot of our clients are on are SureScripts, or specifically your EHR vendor confirming their relationship with the entity like SureScripts and your participation. So confirming that connection either directly or through your EHR. And in that letter, you need to make sure you have the date of onboarding, the description of services, and a description of the network participants. So we are in year 2 of this measure, so your HIE entity or EHR vendor should be well aware of this and be able to point you in the direction you need to. I know NextGen clients, which we work with a lot, you have care quality. If you have that turned on and enabled, then NextGen actually has a link where you can fill out a form and they send you a letter confirming everything listed above. So if you're a NextGen client and you have NextGen Share, I encourage you to go into your NextGen Share hub and see if you have care quality turned on. Maybe a much easier way to meet these 2 measures than before. Our next measure is one that was actually updated this year. So for those of you who answered yes to all of our poll questions, this one's for you. This is a change. So it used to be the Public Health and Clinical Data Registry measure. You had about 5 options to pick from. Think of like cancer case reporting, syndromic surveillance, et cetera. Now in 2022, to better align with initiatives surrounding COVID-19 and kind of overall public health, you can't pick out of those 5. You have to report on both immunization reporting and electronic case reporting, or you have to exclude. So if you do have another public health or clinical data registry, maybe like a specialty data registry that you had continued on from previous years to get credit under this measure, you do get 5 bonus points, which is great, but you do need to look and see if you're eligible for either of these. So you're going to be responsible for proving that you're either in one of the 3 phases of active engagement or you're claiming exclusion. So for active engagement, a good example to prove active engagement would be an email communication from maybe your state registries, screenshots of some sort, or even like a letter, like one shown on the screen. Most registries are going to be really familiar with this requirement and should provide evidence for you if you just reach out. Again, one of my clients did this year and they received this letter. Go to, you could Google your state and electronic case reporting, find an email them and get the process started. If you are actually in production, which I know a lot of our clients are actively sending immunization data, if you provide immunizations, you could use a data report or a screenshot from your EHR that shows either a successful registration or a successful submission of data. Just make sure it includes evidence to support that it's for one of your clinicians. So make sure it shows your provider's name or their NPI or your practice name of some sort. Now, like I said, on the flip side, you only maybe have one of these or you don't have either of these and you want to claim an exclusion for both. You're going to be required to supply some supporting documentation of meeting the exclusion for these. So this is going to look like maybe a data communication, like an email or a screenshot from an immunization registry saying they're not ready to accept data in your state. This is a big one, proof that your providers just don't administer immunizations. If you're a specialty practice and that's not something you do, you obviously aren't going to be required to do that. A big one for this year would be that, communication, maybe it's an email or maybe it's just a screenshot of your state's website that they don't support electronic case reporting yet, either at all or for your specific provider type. So we're seeing that a lot, that there's, ambulatory practices they're not required to submit that data. Or maybe a screenshot or report that indicates that you don't treat or diagnose any reportable conditions for which the state's collecting. This is a big one as well. A lot of states right now are overwhelmed in just collecting COVID-19 data. So again, if you don't diagnose or treat COVID-19, you could exclude. Or for 2022 only, for the electronic case reporting communication, for that one specifically, you could get information from your EHR that they're not certified for electronic case reporting, meaning that their system's not up to date with what it needs to send the data electronically to your state's registry. So lots of different options for exclusions here. The biggest recommendation we have is to really kind of dig into it, start reaching out places. You want as much documentation in your audit binder as possible, specifically for any sort of exclusion for either of these. And last but not least, for the PI category, finally, is our crown jewel, the security risk analysis. The security risk analysis and I have a love-hate relationship. If you can imagine, if a nuclear bomb went off on Earth and something survived, it would be the idea of the security risk analysis. I only mean to say that this thing is never going away, no matter how many program overhauls MIPS or meaningful use or MIPS value pathways go through, this thing will survive it all, mark my words. And ironically enough, this is the most frequent cause of providers to fail an audit, more than any other requirement. So providers should conduct a security risk analysis and update it annually based on changes that maybe were made throughout the year at your practice. Within your security risk analysis, you do need to make sure you have a remediation plan in place for any of those risks that you identified. And the analysis should cover a span of a year. It's not episodic. So ONC and HHS did come together and actually create a free tool designed to kind of guide you and help you through this process for both HIPAA and MIPS. You can see the link on the screen. It basically allows you an executable tool to download, or even Excel versions of this to walk you through things that you can look at if you don't have a place to start. Again, if you don't have the means to do this internally, you can often get outside support or an outside vendor doing this for you. We actually offer this service at DAS Health as well, and we have many clients utilizing this, so they don't have to worry about it. But if you haven't done this yet, this link is your new best friend, and it will likely start probably your own love-hate relationship with the security risk analysis requirement too. Now, in honor of a spooky season, we'll call it, here in October, there are a few myths surrounding the security risk analysis that I want to dispel immediately. Again, it's this measure that's been around forever. It's like an extremely old house that has ghost stories surrounding it. No one actually knows the truth. So consider me your Ghostbuster here. So these are the most common things I hear. One is I have to outsource the security risk analysis. False, and I think you got that from the last slide. It's possible for practices to do the risk analysis themselves using that self-help tool. It does have to be very thorough, though. This is not a one-pager. This really has to stand up to a compliance review. It's going to require expert knowledge, both technical and clinical. So again, we have a lot of clients who obtain services through an experienced outside professional, cough, cough, DAS Health. Sorry, I had to tickle my throat, but it is possible to do in-house. Next is a checklist will suffice for the risk analysis requirement. Again, I think I gave this one away. Checklists are very useful, especially when you're starting a risk analysis, but they're not going to stand up in an audit. No way. Next one is there's a specific risk analysis method that I must follow. So whenever I supply that link, I get a lot of feedback that, oh, we have to do it this way, or if we complete this link, we're going to pass the audit. That's not the case. There is no specific way, process, or model that you have to follow. It just needs to be extremely thorough and help your practice identify and implement effective safeguards to secure that EPHI in your practice. Another one is only need to do this once. That's not true. You need to do this annually. You don't have to reinvent the wheel each year. You just need to update it. But again, it's not a one and done thing that lasts you for each year. And again, this just needs to be done annually. It doesn't have to be within your 90-day PI reporting period. Again, just before the end of the year. And just because we didn't help ourselves, there are some other EHR specific items that we recommend you look into. If you, for the e-prescribing measure, check your drug-to-drug and drug-to-allergy functionality. Sometimes you've got to take a screenshot showing it was turned on. Sometimes this is an EHR vendor letter. Same thing with drug formulary and the API for the patient access measure. Again, sometimes this is a practice-specific thing that's added or turned on, and other times, your EHR vendor might turn it on for all clients across the board. Just a few other things to check into and have proof in your audit binder. Now, the improvement activities, so finally done with PI. That's our next hardest documentation category. Again, on the screen, you're just seeing a reminder of what's actually required. Either way, you need to have at least 1 to 2 activities, depending on how you're reporting. But we recommend that you keep dated documentation on file to support these. So when you go to a test, you're just attesting yes. We recommend that you have, one, that you download that validation file. You can see, an example on the screen here, for instance, for the patient portal one. But you can see they're asking for reports and screenshots. Policies and procedures, PDMP documentation. There are some that might, be training coordination or some sort of training or meetings. That's where we've used meeting minutes and attendee list or training materials. Some might be, engagement or participation in certain things. So that's where we have agreements on file. So again, whatever improvement activities you're reporting on, we recommend downloading that file and, making sure that you have, thorough documentation to back you up in an audit for this. Something else to note, this was actually new in 2020, but if you're actually submitting your improvement activities through a qualified registry, they're going to now require you to validate the documentation. So previously, you said yes, and if you were audited, then you had to show the documentation. Now, if you submit documentation to a registry or through a registry, you're going to have to upload your supporting documentation to support that. If you submit through the QPP, you don't have to do that. The only good thing with this is we're pretty sure, we have a strong feeling that the odds of you getting selected for an audit are a lot less because you had to go through this process already if you're submitting through a registry. And last but not least is quality. Again, I only have one slide on this because it's probably the easiest one to prepare for. It's great considering it accounts for probably the most audits throughout the performance years, but really you just need your certified reports that match exactly with what you submitted. You also need your detailed reports that have that patient and visit level data that we talked about to quickly access and provide examples. And again, we run this for all the statuses, so patients who met the measure, who failed the measure, and even those that were excluded. This way, if CMS audits you and they want different examples for these, you have it, your list is ready. You may also, again, want to download the white papers or workflow guides for these measures to show the workflows for these measures. A lot of them contain the mapping or even scoring logic included in that used for these measures that CMS could always ask you about too. Again, I'm going to kind of blow through these here because I know we're short on time, but some other kind of odds and ends here, mostly related to submission that we would have in there would be really any sort of portal or dashboard screenshots, especially if your EHR or your registry offer any predictive analytics. So if they're going to show you what's your projected score or what's your current score, go ahead and take a screenshot and save that down. Also, any sort of submission confirmation. So if you submit through the QPP, you're not going to be given any sort of confirmation because they just take whatever date is in there on March 31st. If you submit through your EHR or a registry, you're likely given something, whether it's an ID number or whether it's a big green check mark that says you've submitted. We recommend taking a screenshot and saving that down as well. Same idea here, if you reached out to the QPP at all during the year, just save down that correspondence so you have it, mainly the case number, but that can come into play, especially if you ever have to submit a targeted review. And then again, if you ever submitted a hardship, kind of the same idea, save down the documentation that justified this decision to claim that hardship. Again, we're not sure if they're going to audit for the COVID-19 hardships, but things like, the announcement to suspend elective surgeries nationwide, if you're an ASC, that would be a big one, or, staff outages due to COVID-19, if you have a report tracking that data would be key to have in there as well. And then last but not least would be knowing your EHR vendors. Your EHR, this is going to be obvious, and then we joke about it, but at the same time, 6 years later, you could have gone through 2 more EHR vendors. We never know. So having that information and a contact information for all of these, same thing with your patient portal. Is it the same as your EHR? That's great. If it's not, if you're using a different vendor, make sure you have that contact and what portal you are using. security risk analysis. If it wasn't done in-house, you want to make sure you have the vendor you used for that year. Registries on both fronts. So if you used a certified registry to submit your data, or if your registries think immunization and electronic case reporting, make sure you have all communication and letters from them with contact information. BAAs, this has come up in a MIPS audit before. They wanted to see proof of your BAAs to be HIPAA compliant with your vendors. And last but not least, your external MIPS support. If you're currently working with a consulting company like our lovely government incentives team at DAS Health, we can always help have you should have that contact information. We've had clients years later who we aren't even working with potentially now. Maybe they're they moved to a different EHR system, or they got acquired and they already have someone else helping them out, or they have it in-house. We've always assisted in any way that we can, and I think that's an important contact that you should have in there if you worked with someone that year. Okay, so if you have everything we just covered and saved in your audit folder, you should be in a great spot if you're selected. However, there are practices who fail all the time. Clearly ones that don't attend our awesome webinars, but it's important you know what's at stake and why a lot fail. So I'm going to actually turn it over to Bridget to review these. Bridget, it's all yours.
Great. Thank you, Lindsay, for all of that information. Now, I hate to be the bearer of bad news, but as Lindsay mentioned, we do know of practices who fail audits. Most of the time, they start working with us after they have failed one to ensure they have what they need so they won't fail again. Here are some of the most common reasons that practices fail. First, their measure data could not be confirmed. If you don't have those patient or visit level reports saved, and you can't find examples of meeting a quality or PI measure to back up your certified report, they will fail you. Second, the annual SRA was not performed. We have already talked about this one, but it's a big one. Another reason is that the practice was unable to provide requested documentation. Now, I know this seems obvious, but again, this is why we had this webinar today. Sometimes there's inaccurate data that could not be corrected or explained. Again, if you can't back up what you submitted, it is not going to pass. Imagine you are pleading with your case to a jury. They're going to want the facts and examples in black and white, and not a response like, I'm not sure how we got those numbers. Failure to meet exclusion criteria. If you excluded from electronic case reporting, you have to prove how you got to exclude. Did you review your state's condition list and have you saved it out? Do you have email communications with them? Did your EHR give you documentation saying it wasn't ready yet? Whatever the reason is, make sure it's in the folder. And last but not least, failure to comply with any of the audit requests. Again, you only have 45 days to get this information together, but remember, your auditor is also a human being, so work with them and communicate with them to try and avoid this reason for failure. Now, if you do fail an audit for any of those reasons, there are repercussions. Number one is obvious. You will need to return any sort of incentive you received. MIPS incentives are no longer a lump sum payment. It is over the course of a year, so this would be interesting to see since some years will be more than others. And it doesn't just stop there. Once you fail an audit, you are flagged for future audits, either under MIPS or other programs like a HIPAA audit. I mean, this makes sense, right? If you couldn't support what you did for 1 year under the program, you were likely doing the same thing for other years. And let's say you couldn't produce your SRA for the PI category audit, then you would also fail a HIPAA audit. Bottom line, not only do you not want to give the money back, but you also do not want to be on their radar. While chances are small, there is also potential that further enforcement could be taken if they find any evidence of fraud or bigger issues. Those things could lead to temporary or permanent exclusion from Medicare, additional monetary penalties, or even prison. Now again, we are talking much bigger issues than not being able to support your MIPS data. We are talking falsified billing, fraud, or other more serious things that may come out when they look at your data for a year that's based on your claims submitted. All right, well, we're a week out from Halloween, so consider that your scare for the month. Let's switch back and end on our overall audit documentation recommendations that we haven't explicitly touched on from your DAS Health GI team. I'm going to turn it over to Kimmy, who will take us through these. Cami?
Thanks so much, Bridget. That was awesome. So let's start with ownership over the audit binder or folder. We have a golden rule or rules when it comes to accountability, and they're pretty simple. You don't want to be the only one, and you want to know who, what, and where. So what does it mean when we say don't be the only one? We mean you should not have only one person responsible for this at your practice. There need to be multiple people who, and get ready for this, know what is contained in the audit binder and the what each document is for. Know where the audit binder is stored, either paper, electronic, or even where the backups are. You want to know who has access to the file and the binder and who's responsible for maintaining, updating the file, and who will handle in case of the transition. We see this all the time where there is a new office manager or practice contact that we are working with, right? And they have no idea what the person before them did and where they saved things, which can lead to issues if you were audited multiple years back. So think of practice turnover or position transitions as well as if you are solely responsible and something happens where you're out for an extended period of time and cannot assess. There needs to be more than one resource at your practice that knows who, what, and where of your MIPS audit folder for consistency and to ensure you can pass the audit. Think of it this way. If you did all of this work to make sure your practice or providers were prepared for an audit, and then you leave, retire, or move to a new position, and the practice fails the audit because no one knows where you stored the folder on a shared drive or where you physically stored the binder in the office, it's hard to think ahead to a future that can seem improbable, and just know that the prep that you do right now will prevent headaches and stress in the future. Failing an audit would be disappointing and frustrating with all the work that's been completed, and having no documentation or not knowing where the documentation is to show for it. So let's make sure that doesn't happen. Going off that last point, your folder may be on a computer or in a physical binder or both. Maybe 27 and 2018 are on paper and 2019 and onward are electronic. There are no rules surrounding this on what it needs to be, but there are some pros and cons to each. So if you do choose to go the electronic route, when you have space saving, there are electronic documents that take up minimal physical space, or they're easy to use, and computers allow for easy folder share and copying, and not to mention an online portal where you have to upload the evidence for audits is the norm. So this does make it convenient because they're searchable and can search for by utilizing the keyboard shortcuts like the Control F function, which I use all the time. And these documents can be downloaded to your phone or device if needed. And also, that data remains in the same condition, unaffected by the environment, and will not wear, tear, or fade. So overall, that's why wouldn't you choose electronic, right? But there are also cons that you should consider. And those can be your software risk, right? So computers and servers can fail. And unfortunately, if you don't have it backed up, you could lose it forever. There's formatting risks, like media versions can change or become obsolete, making the files hard to open up or share. And lastly, overall security risk. And I know we have all heard of ransomware and hackers, and this could happen even unintentionally if it's on a computer or drive that houses patient data that they could be targeting. So why would we consider paper binders, right? So pros, it's reliable, it's a trusted format. Everyone accepts paper. Everyone's familiar with paper, and you can always open paper without issues. It also may be necessary for any documents like your original EHR purchase that required a signature. So what are the cons for paper? Obviously, it kind of plays off the pros for electronic, but you've got to consider physical storage. It takes up a lot more physical space in your office. Not only that, but the chance of decomposition. What if there's a roof leak or it's humid or someone spills their coffee all over everything? It's even harder to share since it would require scanning and then uploading and sending. Lots of upkeep, right? And there's still a security risk. Is this kept in a place that is secured or locked? And who has access to those rooms if it is locked, if you have to get to it? So now we aren't here to say which format is best, if It's your practice's preference. And we've seen both. Our recommendation at this point is to have an electronic folder saved to a shared secured location and also have paper copies of the extremely important documents such as your EHR purchase documentation and your security risk analysis. So how you set up your binder or electronic folder will depend on if you report it as a group or an individual. If you report it individually, you'll need everything we listed in the previous section for each provider and clinician you reported for. We recommend creating space or separate folders for each clinician reported for electronically, and maybe sort by tabs or file folders if you have a physical copy. There are some things like the EHR purchase info or the SRA that will apply practice-wide and can be kept in one communal place, but mostly category data and documentation will need to be separate. So if you report as a group, you can save down the documentation at the TIN level. This is much less work because you should only have one set of documentation for the entire practice that year. Again, very important you have those lists included of which providers and NPIs that were included in your group for that reporting year. So now that we have outlined what to include in your audit files for each MIPS performance year, you want to make sure that documentation for up to 6 years is in order to be in accordance with the False Claims Act. The 6-year timeframe also allows CMS the ability to request any records or data retained for MIPS purposes within that window. This was finalized in 2019 by the QPP final rule and is for all MIPS performance categories excluding cost, considering no data has been submitted for the MIPS cost category. They say you need to hear something at least 3 times to remember it, and we have said keep your MIPS audit documentation for a minimum of 6 years about 100 times within the past hour. So I think we're good. One thing that is often overlooked when retaining the documentation necessary for your audit preparedness, that you respect the HIPAA minimum necessary standard. Be sure to redact or blur any PHI or protected health information if/when the auditor requests specific records. If the piece of information is not required to fulfill the purpose, keep it out. Typically, any documentation sent to the auditor will be shared via secure file sharing platform or a secure fax if requested. But make sure you ask your auditor if you have PHI you need to share and that it's done securely. Not a great look if you send PHI without it being secured. Odds are they'll flag you for a HIPAA audit, may or may not go up.
Perfect. Well, thank you so much, Kimmy. Sorry, I'm actually just going to go ahead and jump in here and really review our recommendations or really summarize everything we went over today. So, again, these 2 slides at the end here, I know I'm sorry we're over. We just have so much MIPS information we want to share. We'll provide a really great summary of all of our recommendations. Again, just to point out a few here, make sure you're creating an audit file for each MIPS performance year. And we recommend you create a checklist for all that required documentation so you have it. I did see a question come through in the chat about, if we have a documentation checklist. We definitely have a checklist, internally, but it will depend on your system, and your practice and how you're reporting. So we always recommend that you kind of take this slide deck and almost go through and make your own checklist that would apply for your practice as well. Obviously, if we're working together on an ongoing support basis, we do, assist and provide that guidance. Make sure when you're providing any documentation in the form of screenshots to include the date and time in the bottom right-hand corner of your screen. This is a big one. I see this happen a lot. You might have taken a screenshot to prove something, workflow-wise, etc., and you forgot to include the date and time, or at least the date in the lower right-hand corner. There's no way to prove that that wasn't taken yesterday, if it's 3 years later and not in that reporting period time frame. So to make sure to do that as well. And then last but not least, work with and communicate with your auditor. If you can't meet a deadline, let the auditors know. If you have questions about information being requested, ask the auditors for clarification. Auditors are people too, or at least we were pretty sure, right? So they should be able to work with you. They're going to be more likely to work with you if you're responsive versus just trying to ignore things or figure it out on your own. You're going to have much more success and a more pleasant experience the more you communicate with them on any issues you may have. And kind of lastly here, our team's trusted advice from years of experience at this point with audits. You can never be too cautious. You can never have too much documentation. Like I said, I tricked you all into attending today with that title. Just put it all in there. If you think it applies, there's no harm in saving it. Make sure you have that binder or that folder ready to go before you even consider submission. This is typically an afterthought, in previous years. That's not the case. Your audit file, binder, et cetera, should be done when you submit. And again, most importantly, it's a team effort. It's not a single person's responsibility. But I understand, we have a lot of small practices or even larger practices, but we don't have the resources here to help out or have a team. Just sit someone down, whether it's a provider at your practice, a clinical staff member, an administrative team member, your work bestie. I don't care who it is. Take 30 minutes and make sure someone else, again, knows that who, what, and where of your audit binder or audit folder. Well, that is it. A little over time, but we did make it. Next steps, besides going to make your own audit folder, for those of you who said no right now, would be to continue to sign up for our webinars. If this did seem super overwhelming, or you want another set of eyes looking at your data, or really taking this over for your practice, consider working with our government incentives team to offer guidance on these topics exactly like this. You'd be working directly with myself and Kimmy and Bridget, who you heard talk today. And again, we're happy to assist with any questions you have. If you are interested, reach out to your DAS account manager. If you're not a DAS client, feel free to reach out to me directly, and I will put my contact information up on the screen. Chelsea, I'm sorry, don't kill me that we're over, but we can go ahead and jump into questions. I think we're all okay to stay on line a few more minutes if we had any come through.
Okay, perfect. Thank you, Lindsay, and thank you, Kimmy, and everybody for joining us today, and Bridget as well. I'm glad that you were able to make the time to be with us. Okay, so I'm just going to go through the questions in the order that they were received. A couple of these might be tricky, Lindsay, because they came while you were talking, so good luck.
Okay.
So the first one was about 20 minutes in, so this was fairly close to the beginning of the presentation. Who would the email go to?
Got it. I can grab this. I'm assuming it's the notification of an audit email. So it's going to be whoever CMS has contact-wise at your practice or your tax ID. A great place to look at this would be to log into your HARP account. So that's the kind of the new admin master on the CMS side of the house. If you have a QPP portal or your HARP account to see who's connected to your practice, the practice contact. You could also log into PECOS, the PECOS, and double check that as well. But we recommend making sure that that stays up to date. Another great reason that if you have a lot of turnover in your practice, you are making sure that you have multiple people connected to your practice through that QPP portal as well. That's where they're going to get their administrative information.
Okay, thanks, Lindsay. Next one. Does being a member of an advanced APM change the audit documentation requirements?
I can grab that one too. Sorry, Kimmy and Bridget, if you have more comments, feel free to jump in. But a quick answer, yes. So if you're part of an advanced APM, you're exempt from the MIPS pathway. That's an entirely different pathway. However, the verbiage of this, or how this is phrased, I want to call out, it's not just being a member of an advanced APM. You have to be a QP or qualifying participant, which means you hit certain thresholds to be part of that, or at least considered in CMS's eyes part of that APM, which will exempt you from MIPS. If you're just a member of an APM and you didn't hit that QP status and you still have to report on traditional MIPS, the audit requirements do not change.
Okay, perfect. Next one. Kimmy, I think I'll send this to you. What if I accidentally sent my audit document securely, but there is PHI present? Will I be penalized by my auditor?
That's a great question. So in short, no, but here's what we want to make sure that we have. PHI can be so intimidating, especially if you're like me and you're paranoid that even though you checked something several million times, there could be something your eyes just missed. So best practice is to never send PHI unless it is specifically requested through a secure portal upload or secure fax. There is a chance your auditor will request patient examples for some things. However, when adding supporting documentation to your audit binder, take care to review the documents and contents closely, and you'll not get penalized for the document containing PHI since it was sent securely. It never hurts to have another team team member who is familiar with the audit process review the documents as well, just to build that, sort of familiarity with the documents that are needed for your audit.
Okay, perfect. Thank you. Next question. Lindsay, I'm going to hand this to you this one to you again, but it might be a little bit tricky again because it was referencing a specific point in your presentation. Can you repeat where the document you just discussed is?
Oh boy. Trying to look based on timing to see, but I unfortunately do not. Again,
That's okay. That person's left, and so we'll just follow up with them directly with the slides. So, and just as a reminder, we will be sending out a copy of the slides and the recording to everybody who registers. We do try to do that for all of our webinars so that, even if you know that you're not going to be able to make the next one, but it's information that you want, please go ahead and register anyways. That way you'll be sure to get the slides and recording. Okay, another question here. Bridget, I think this one's for you. Can you go over where we would access the CMS audit recommendations again?
Yeah, of course. As Lindsay mentioned, the CMS has MIPS data validation zip file that is available every year. This is going to have your audit requirements and provide guidance for you. So to access information, you're going to go to the QPP webpage, and that is qpp.cms.gov. And at the upper right-hand corner, you're going to see the word resources, and you're going to click on there, and there's going to be like a drop-down menu. On the drop-down list, you're going to see the option called Resource Library, and this holds a lot of data. Once you've clicked on the resource library, there's going to be a search bar you can type into. So you'll type data validation, and then you'll be able to download the data. Just make sure you are choosing the correct year, because there are years that it can default to. But again, if you guys have any questions about that, please do not hesitate to reach out to Lindsay.
Okay, perfect. Well, it looks like that's all of the questions that we received. If you have any more, you've seen Lindsay's information up on the screen. Feel free to reach out to her directly, of course, to your DAS account manager if you have one. And always, you can reply back to the emails that I send. Like I said, I'll be sending one with a link to the slides and recording. So basically, any way that you can get a hold of us, we're happy to help. So don't hesitate to ask. And just because I am marketing, I do feel like I need to point out that, as a reminder, we do the security risk assessments that Lindsay spent quite a while talking about in the beginning of the presentation. So if you'd like more information on those as well, don't hesitate to ask. We're happy to help. And thank you, everybody. Appreciate you joining us today. And for those of our next-gen clients, we look forward to seeing you in about 2 weeks here at UGM. Stop by and say hi. Lindsay and I will both be there.
Absolutely. Can't wait. Thank you all again.
Have a great day.